My name is Dawoud Kindi, intervention cardiologist in Nizwa Hospital from Oman. I am presenting this case, the shelf beneath the surface, overcoming an ambiguous LAD with IVUS side branch precision. Our patient, he's a 51 years old male diabetic hypertensive. He had interstitial disease on hemodialysis from AV fistula on the right upper limb. He was admitted late last year with non-STEMI. Ejection fraction at that time was normal. Before his admission, he had an intervention to block his right AV fistula, and there was a chymosis and hematoma. And during his Calvert admission, his blood culture, he showed signs of sepsis, blood culture gross staph aureus. There was no vegetations on the valves, and he was treated with antibiotics for the infection. And the vascular team advised to delay the angio. So the patient, he was treated medically and discharged home. So he was seen in the clinic after 2 months, and coronary angio was done for him. So you can see here, he has severe calcific stenosis of the mid-RCA, and also he has severe stenosis of the BDA. And for the LAD, as you can see here, he has semi-functional CTO, faint and degrade filling after this large septal branch, second large septal branch, and this is large diagonal with inferior branch. So the patient, he was taken off the table, discussed with him surgical option first, but the patient refused to go for CABG. So the patient, he was taken back to the cath lab for BCI after a few days. So BCI was done to the RCA initially. It took a lot of time because of the calcification that was underestimated with the angio. So BDA first, and then stenting, predilatation, aggressive predilatation, and stenting of the mid-RCA. So this is the final results. And just to know that there was no collaterals from the RCA going to the LAD, either at the diagnostic or even after finishing the procedure here. So the patient was discharged home and then planned for staging BCI to the LAD. So patients came back after probably 1 month. Because we went femoral because there was, since the beginning, he has hostile anatomy, calcific femorals. Trying to go through the right femoral, it was extremely difficult, so we went through the left femoral artery. Trial was done with multiple wires, BMW run through, fielders, and pilot 50. Initially, we thought there was a small channel so you can go integrate wiring and then you will cross to the LAD, but that was not the case. So after multiple trials, the operator opted just to stop the procedure and then to send the patient for tertiary care. At that time, we didn't have intravascular imaging in the hospital. So these are the final results. There are some loss of the flow, but there is a faint filling, late filling of the LAD at the end. So the patient, he was seen in the clinic after 2 weeks. He has some mild shortness of breath. He was awaiting the appointment, but later on he came back with more symptoms. Echo, it didn't show any reduction in ejection fraction. It was preserved. And he was not able even to walk for 200 meters without symptoms, provided that we have more equipments, all CTO tools, and also IVUS was brought. So we discussed with the patient, and he agreed to have another trial and attempt to the BCI to LAD. We discussed the case as a team. We plan to go, we were not going to repeat the same. We go with workhorse wires, but we plan to go 7 French femoral, IVUS guided. We use polymer jacket and angled microcatheter. And then we'll take it from there. So this is the initial angio. The patient, again, he has faint filling. I didn't include that. We shot first the right. There was no collaterals from the RCA. And because of the difficulty of the access, we just went with one access only. This is the angled microcatheter, is Ninga Swift. It's you can adjust the angle with this microcatheter. We tried to go where we thought that from the previous angio, where it was the entry to this LAD, but we tried with multiple wires, starting with cyan black and then other polymer jacket wires, pilot 50, 150, but it was, we couldn't be successful. Later on, we did open sesame technique. We said that we may open the takeoff of the LAD, but again, the same results. Ballooning, it didn't show anything. So then we went to do IVUS as we planned ahead. So this is the IVUS image. So this is IVUS run from the diagonal to the LAD. As you can see here, if you notice this, so just again, I want to play from the beginning. So here we go. Oh, sorry. So just I will show you here, you can see there's a shelf of calcium just beneath the intima, and here's the LAD. So that's the shelf of the calcium actually was preventing all of our wires just to go to that small channel beneath it, as you can see here. So this is like a snapshot. So this is the calcium, this is the LAD, and we trace it like just before we reach this frame, there was like the LAD going, and this is like the shelf of the calcium, this is the intima, and here is the LAD. So what we did, this is the wire with the IVUS. We parked the IVUS exactly at that spot, and then we brought microcatheter fine cross with the Gaia second just to go through that shelf of calcium. And we did like two angles on this Gaia second, and it was actually successful. So just knowing what was preventing the wires from going in, it gave us like the clue, and it went all the way. And here is like the wire, as you can see. So this is the shelf of the calcium. So you can see this is the wire, usually crossing through. This is the wire. We did another run from the diagonal. So this is the wire. You can see the wire just crossing this shelf of calcium into the LAD. And the rest we just confirmed. This is the microcatheter. We confirmed that this is the position as from the initial angiogram. And here's like an injection to this microcatheter. As you can see, this is the LAD, and there was like no dissection because it was only a small shelf of calcium at the entry of the LAD. The remaining, so we exchanged the wire with workhorse wire, and we did IVUS for the LAD just to know the size, and to blend like we look for the healthy part where we'll land our stent, and blending with the IVUS, we did ballooning, did stenting, and this is the final results. So the remaining was just provisional, the remaining was just simple PCI. So these are the final results. So follow-up, the patient was asymptomatic. He was taking his medications, preserved ejection fraction, and the take-home message from this case, intravascular imaging is important tool in the cath lab, and IVUS is valuable imaging modality to identify any ambiguous cap or any lesion takeoff, and allows real-time actually cap puncture. Preparation and planning with the cath lab team before you go to such cases is the success key. Thank you very much for listening.